Plateau iris configuration is a special mechanism of primary angle closure glaucoma. It occurs when the ciliary processes are positioned too far forward, pushing the peripheral iris and making the iris look flat in the center, but steep and rolled at the edges. This keeps the angle dangerously narrow. On gonioscopy, the key diagnostic tool, you'll find a narrow angle, usually shy grade 1 to 2. A characteristic double hump sign appears on indentation, caused by the rotated ciliary body. The peripheral iris looks flat, or plateau-like, with no significant iris bomb. The treatment of choice is argon laser peripheral iridoplasty. This procedure contracts the peripheral iris, pulling it away and opening the angle. Let's proceed with the next question. Ghost cell glaucoma. Ghost cell glaucoma is a secondary open-angle glaucoma. It happens when degenerated red blood cells, known as ghost cells, block the trabecular meshwork after a vitreous hemorrhage. Here's the process. First, red blood cells enter the vitreous during hemorrhage. Over the next 1 to 3 weeks, they degenerate, lose their hemoglobin, and become ghost cells. These ghost cells then migrate into the anterior chamber through the hyaloid face or zonular defects and obstruct the trabecular meshwork. The result is a rise in intraocular pressure with an open angle. On slit lamp, you may see tiny, yellow-brown refractal cells floating in the anterior chamber. Gonioscopy shows an open angle, sometimes with pigmented debris on the trabecular meshwork. Management depends on severity. Mild cases may resolve with observation and temporary medical therapy to lower intraocular pressure, but in severe or persistent cases, an anterior chamber washout is required. Let's proceed with the next question. The superior temporal retina is the most common site for retinal detachment, and here's why. First, the vitreous base and traction. The vitreous base attaches most firmly near the ora serrata. When posterior vitreous detachment occurs, it creates strong traction at the peripheral retina, especially in the superior temporal quadrant. This is because the temporal retina has a larger surface area and the vitreous is more adherent in this region. Second, gravity. Unlike inferior breaks, gravity does not protect superior ones. Subretinal fluid tends to collect downward, making superior breaks more likely to progress into symptomatic or extensive retinal detachments. That's why they are the most clinically significant. Let's proceed with the next question. Retinoblastoma is the most common primary intraocular cancer in children, usually diagnosed before the age of 5. Clinically, it often presents with leukocoria, the white pupillary reflex. Other common features include strabismus, a red painful eye, or decreased vision. Ultrasonography plays a central role in diagnosis. On B-scan, the single most specific finding is calcification within the intraocular mass. These appear as bright, highly reflective foci with acoustic shadowing and are considered almost pathognomonic for retinoblastoma. Other ultrasound findings can include vitreous seeding, retinal detachment, or a vascularized intraocular mass. However, these features are not unique to retinoblastoma and may be seen in other tumors or conditions. That's why calcification on B-scan is the key ultrasonographic sign to confirm the suspicion. Let's proceed with the next question. Neovascular, or wet age-related macular degeneration, is marked by choroidal neovascularization. These abnormal vessels leak and bleed, causing rapid central vision loss. The primary site of pathology is Bruch's membrane. This thin layer separates the retinal pigment epithelium from the choriocapillaris. In AMD, it thickens, accumulates drusen, and develops tiny breaks. Through these defects, choroidal vessels grow into the sub-RPE or subretinal space, forming the hallmark neovascular membrane. So, Bruch's membrane is the key structural site driving wet AMD. Let's move on to the next question. Proliferative vitreoretinopathy, or PVR, is the leading cause of failure after retinal detachment surgery. It is defined by the formation of fibrous membranes, both on the surface of the retina and beneath it. These membranes contract, pulling on the retina and leading to recurrent detachment. The main cellular source of PVR membranes is the retinal pigment epithelium, or RPE. When a retinal break occurs, RPE cells migrate into the vitreous cavity. There, they undergo a process called epithelial to mesenchymal transition, transforming into myofibroblast-like cells. These transformed cells produce collagen and contractile elements. Because of their strong contractile properties, RPE cells are considered the most important players in the development of PVR. Let's move on to the next question. Keratoconus is a progressive, non-inflammatory corneal ectasia. It is characterized by stromal thinning and protrusion, which result in irregular astigmatism and visual distortion. Topography detects the earliest changes before slit lamp or clinical signs appear. The earliest topographic sign is inferior corneal steepening compared to the superior cornea. Quantitatively, this is described as an inferior to superior, or IS, asymmetry greater than 1.4 to 1.5 diopters. This finding reflects localized steepening and thinning in the inferior cornea, and it appears before any obvious curvature changes, such as high keratometric values or visible clinical signs. Let's move on to the next question. Morin's ulcer is an idiopathic, progressive, and painful form of peripheral ulcerative keratitis. Unlike other types of PUK, it is not associated with systemic vasculitis or collagen vascular disease. The exact cause is unknown, but it is believed to be autoimmune in nature. It is characterized by a crescent-shaped ulcer in the peripheral cornea with an undermined leading edge. Importantly, there is no associated scleritis or systemic vasculitis. Management begins with medical therapy. Topical corticosteroids are the first-line treatment. In aggressive or bilateral cases, systemic immunosuppressants may be required, such as cyclophosphamide, methotrexate, cyclosporin, azathioprine, or mycophenolate. Surgical intervention is considered for non-healing or progressive ulcers and in cases of impending or actual perforation. Options include conjunctival resection or peritomy to reduce immune cell influx, lamellar or penetrating keratoplasty, amniotic membrane grafting, and in cases of perforation, cyanoacrylate glue or patch grafts may be used. Codeduced line is a linear collection of keratic precipitates on the graft endothelium, starting in the periphery and progressing centrally, is the hallmark of corneal graft rejection. This represents a wave of donor endothelial cell destruction driven by host immune cells. Rejection can occur at any time after corneal transplantation, from days to years, but it is most common between 2 and 6 months. It is an ophthalmic emergency, requiring immediate treatment to preserve the graft. Medical therapy includes high-dose topical corticosteroids, such as prednisolone acetate 1%, applied hourly. For severe or central involvement, systemic steroids are added, either as oral prednisolone or intravenous methylprednisolone pulse therapy. Let's move on to the next question. Lineus conjunctivitis is a rare, chronic, and recurrent form of conjunctivitis. It is characterized by the formation of thick, woody pseudomembranes on the tarsal conjunctiva. The underlying defect is a deficiency of plasminogen, which leads to impaired fibrinolysis. Because fibrin cannot be properly degraded, it accumulates and forms firm membranes on the conjunctiva. The pathognomonic sign is the presence of woody, fibrin-rich pseudomembranes, most commonly on the upper tarsal conjunctiva. These membranes are recurrent and resistant to simple removal. Management focuses on restoring fibrinolysis and controlling inflammation. Treatment options include topical or subconjunctival plasminogen, or plasminogen activators, such as tissue plasminogen activator, or TPA. Topical heparin may also be used to reduce fibrin deposition. Topical corticosteroids help reduce inflammation, although they are limited when used alone. Other options include topical immunomodulators, such as cyclosporin or tacrolimus. In severe multisystem disease, systemic plasminogen replacement therapy may be required. Horner-Trantas dots are small, white to yellow, gelatinous spots seen at the limbus. They are composed of collections of degenerated epithelial cells and eosinophils. These dots are considered a classic sign of vernal keratoconjunctivitis, especially in the limbal form. Let's move on to the next question. Spherophakia refers to a small, abnormally spherical crystalline lens, with increased antero-posterior thickness and reduced equatorial diameter. Because the lens is highly convex and positioned more anteriorly than normal, it leads to a shallow anterior chamber. This anatomical change predisposes to pupillary block, which causes iris bomb and results in secondary angle closure glaucoma. Importantly, this is the most common glaucoma mechanism seen in spherophakia. To be continued.